The Temporomandibular Joint, TMJ, Key Concepts for Physical Therapy Management. TMJ Overview. The TMJ is a bilateral diarthrodial joint connecting the temporal bone to the mandibular bone. It is the most used joint in the body, active during speaking, chewing, and swallowing. TMJ Functional Anatomy. Key structures: temporal bone, mandibular condyle, fibrocartilaginous disc, ligaments. Unique features: the disc divides the joint into superior and inferior compartments, allowing both rotation and translation. Muscles of mastication. Primary muscles: masseter, temporalis, medial and lateral pterygoids, suprahyoid and infrahyoid muscles. Functions: elevation, depression, protrusion, retrusion, and lateral excursion of the mandible. TMJ kinematics. Mouth opening, depression, early phase, anterior rotation of the condyle, late phase, anterior translation. Mouth closing, elevation, reverse sequence of mouth opening. Protrusion and retrusion. Protrusion: mandibular condyle and disc translate anteriorly. Retrusion: mandibular condyle and disc translate posteriorly. Lateral excursion. Mechanism: involves spinning of the ipsilateral condyle and horizontal translation of the contralateral condyle. Pathokinematics: disc displacement. Anterior disc displacement with reduction, EDR, disc reduces back on the condyle during mouth opening. Anterior disc displacement without reduction, EDWAR, disc remains anterior to the condyle throughout opening and closing. TMJ dysfunction symptoms. Common symptoms: pain, limited mouth opening, joint noises, headaches, dizziness, earache, tinnitus. Dental considerations. Occlusion types: normal occlusion, overbite, overjet, crossbite. Significance: occlusal relationships impact TMJ function. TMJ examination techniques. Palpation: assess masticatory muscles, joint capsule, and ligaments for tenderness and dysfunction. Range of motion, ROM, measure mouth opening, lateral excursion, protrusion, and retrusion. Differential diagnosis. Articular disorders, disc condyle incoordination, fractures, ankylosis. Masticatory muscle disorders, myofascial pain syndrome, myositis, trismus. Physical therapy management. Patient education, emphasize posture correction, oral habits modification, and soft diet. Therapeutic exercises, focus on muscle coordination, strengthening, and stretching. Manual therapy techniques. Joint mobilization, longitudinal distraction, anteromedial translation, lateral and medial glides. Soft tissue mobilization, techniques for masseter, temporalis, and pterygoid muscles. Special techniques. Spray and stretch, use of cold spray and passive stretching for muscle relaxation. Dry needling, targeting myofascial trigger points to reduce muscle tension. Managing chronic TMJ disorders. Multifactorial approach, address chronic pain, stress, and psychological factors. Research evidence highlights the effectiveness of physical therapy in reducing TMJ symptoms. Surgical and medical management. Indications: surgical intervention for severe, unresponsive cases. Common procedures: arthroscopic surgery, splint therapy, corticosteroid injections. Case scenarios. Example cases: apply clinical reasoning to diagnose and manage TMJ disorders using evidence-based approaches. Research highlights. Recent findings, updates on TMJ biomechanics, imaging markers, and treatment efficacy. Future directions, exploration of genetic, epigenetic, and neurobiological factors in TMJ disorders. Conclusion. Summary: integration of anatomy, clinical examination, differential diagnosis, and management techniques for effective TMJ care. Key takeaway: comprehensive and evidence-informed approach to TMJ management improves patient outcomes.